There we go. So I'll be talking to you today about a little bit about the Da Vinci surgical robot, but I really do want to put it more in the context of the larger healthcare decisions that we're making, and also talk about ways in which technology will be able to take us to the next level. So initially, to put a lot of these things in context, I'm going to show you a few dry slides at the beginning, which are going to talk a little bit about some of the demographics that we're looking at in healthcare, both here in the Middle East and North Africa, and also in comparison to what we're seeing in the US and in Europe. And so this slide here is life expectancy versus income in terms of GDP per capita. And you can see from the regional variations on this slide that the Americas are in yellow, the Europe is in orange, the Middle East and North Africa is in green, and Sub-Saharan Africa in blue, and then Indian subcontinent and Australasia. And what you see here is a fairly linear relationship between life expectancy and income per capita. And we see that with the countries like Europe and the Americas and the Middle East are all up in a fairly linear area where we're seeing life expectancy increase with GDP. When we shift that to food supply versus life expectancy, we'll also see that these same countries that are relatively wealthy also have a fairly high number of kilocalories per person being produced in that country. And a little bit less linearly, this is generally positively correlated with life expectancy. But if we start looking at the food supply in kilocalories per person versus the body mass index, we start to see some of the negative effects of these are the diseases associated with wealth. As our societies move up the income, we also have more food available, and we are all dealing with issues of obesity and the gradual increase of body mass index. And you can see that the Middle East and North Africa is sitting squarely in the middle of the Americas and Asia and Europe in this regard. Now we start to look at some of the other effects associated with body mass index. And as obesity starts to climb, so does cholesterol, and so does cardiovascular disease, and so do many of the diseases that we think of or we associate with diseases of affluence. And these become very big public health crises as this continues to grow. So let's go back to that income per person and that life expectancy. That income is now giving us the ability to feed our populations, and in some cases overfeed our populations, and we're starting to deal with the issues associated with that. There are also other diseases that come with longevity, and longevity in and of itself seems like a good and noble goal, but our healthcare expenditures will start to go up and up as we are dealing with the consequences of this longevity. So if we look at cancer rates, life expectancy, and now we're looking at cancer rates, we see a departure from some of these linear relationships. It looks, to a certain degree, like North Africa and the Middle East gets a little bit of a pass on cancer rates. And so even though the life expectancies are the same as we're seeing in Europe and seeing in the Americas, the cancer rates are off that curve. They're better. But this is a bit of a false sense of security here. And that's because when you look at the ages, or the average ages of these different populations, the demographics are very different. Asia and Middle East and North Africa is considerably younger in its average age of the population. And so you will also be getting your silver tsunami, where everybody in Europe and the Americas is looking at this aging population and looking at the burden that the diseases associated with aging are going to be placing on our healthcare systems. And this is something that initially will not be hitting the Middle East as hard. And that's primarily because the population here is considerably younger. But this will change as the demographics are changing. And so the important thing, and this may sound kind of funny coming from someone who is technology-oriented and therapy-oriented, but we all must be focusing on prevention, because the most cost-effective cancer treatment is preventing a cancer. And the most cost-effective therapies for heart disease are preventing that heart disease. Now, I live in a world where prevention hasn't worked. We get cancer, we get heart disease, and then this is where the technologies that I work in start to come in. And when you invite surgeons, you get surgical pictures. So I'm going to warn you that my next one is, this is where I come in. And so right now, our options, and traditionally our options have been that when prevention fails, we can turn to surgery in order to correct the cancers or to be able to treat the problems associated with the obesity or heart disease. And until the 1980s, this was your option. A large open incision, get your hand inside, your eyes inside, and you can treat the body directly with direct manipulation. In the 1980s, laparoscopic technology came out and allowed a lot of these surgeries to be done through very small incisions. But the complexities of many cancer operations and the complexity of even things like a gastric bypass, which this is a still from one of those surgeries, meant that minimally invasive options for these types of surgeries were really not very prevalent. They were too complicated to be done in this minimally invasive way, and open surgery was really the only option. So in the 1990s came the technology, which is the Da Vinci surgical robot. And that is the company that I work with, and I do a lot of research in looking at how we can improve these technologies. And what happens is for every motion of the surgeon's hand, the small metal instruments inside the body are making exactly that same motion, so that you can operate inside the body, in this case, inside the heart, and doing a repair of a mitral valve directly without ever having to crack open the chest, being able to place very small instruments through small incisions. And it's the development of robots like this that have allowed minimally invasive surgery to replace a lot of open surgeries around the world. And so ORs are starting to look like this. And there are a lot of opinions about whether this is a good thing or a bad thing, because as we start to bring in a lot of technology in order to allow the minimally invasive surgeries, we have to ask, is it worth it? Is getting rid of that open incision something that is going to improve the general health, or is it something that's just going to break the banks of our collective healthcare systems? And so for the patient, this makes a really big difference. We go from being able to do surgery through big incisions to being able to send people home with a few Band-Aids on their belly. And so as far as the patient is concerned, this is a good thing. But who's paying for this? And how do we pay for it as a society? So one of the ways in which it's being justified and it's being paid for is through improved outcomes. So this technology has been out for about 10 years in widespread use, and it was adopted ahead of large amounts of evidence. It was adopted on the promise that the smaller incisions were going to lead to better outcomes. But it's only been in the last 2 years that we've seen very large population-based studies where there have been more than 40,000 patients in a particular study looking at across-the-board improvement in outcomes or changes in outcomes. And what we've seen worldwide in prostatectomy is that the complications are reduced by about 60%. The readmissions are reduced by 2/3 as well, so patients after exiting the hospital having to come back to the hospital for complications, and the mortality is down 85%, 83%. What we see in colon resection is the complications are cut in half, readmissions are dropped by almost 20%, and the mortality is also 80% down. And when we look at hysterectomy, which is one of the fastest growing procedures and actually the dominant procedure that is being done now worldwide in terms of numbers, the complications are down 72%, readmissions down 85, 86%. We don't see a big change in mortality because open versus Da Vinci, the mortality rates are very low, so that's not significant. And so we see the value as far as the patients are concerned, and we see the value in terms of admissions, but is this going to be able to do enough? It's led to the adoption of about 2,700 robots worldwide. They're in 30 countries. And when you start looking at why these countries have adopted the Da Vinci, it's somewhat different depending on where you're going. So the United States was very early adopters. And it was largely a competitive model, as you might expect out of US healthcare, where it's hospitals competing against one another. And what we saw was one hospital would buy a Da Vinci robot, and they would market against another hospital, and they would say, we have the latest technology, and all the patients would go over to that hospital, and the hospital without a Da Vinci would start losing its patients. And so this was sort of the arms race method of adoption, because then what we would see is the other hospital in defense would get itself a Da Vinci, and it would lure back some of its other patients. And pretty soon in the United States, every hospital had a Da Vinci, and it was the playing field was level. But what we saw was a very interesting change in that adoption pattern. And we started seeing some hospitals get multiple Da Vincis. And it turned out that the more vertically integrated that hospital was, the more it was getting additional Da Vincis. And so looking at the economics of one hospital versus another, one that's heavily invested in Da Vincis and one that has only one, what we saw was that the CFOs of those hospitals, as they got more of them, continued adding additional ones. We have some hospitals that have 7, and they have 7 dedicated ORs that they're running all of the time. And what they're doing is patients are getting out 2 to 5 days earlier, and their complications and their readmissions are way down. And so what they're doing is they're investing in robots instead of investing in the bricks and mortar of building additional hospital rooms, because it costs on average in the United States $1.7 million per hospital bed, a postoperative hospital bed. And instead, they were filling their ORs with Da Vincis and getting greater throughput on their outbeds. We saw also that the more vertically integrated the decision-making in like the Kaiser healthcare system, where there are, the hospital owns the hospital system employs all of the surgeons and has a group that they're insuring. The patients are all part of the same ecosystem, that they would get very, very high utilization of this initially high capital equipment, high capital investment. And then they would we would joke, they used it till the bolts fell off. I mean, they got the highest number of cases per year out of any systems anywhere in the world were being done in these sorts of systems, these hospital systems. And so when you look up at a country like Canada, where they are overall more vertically integrated, the government is much more responsible for the general healthcare provision. They started looking at the health technology assessment costs per use of this. And they also found that the more they used this equipment, the more money they were saving. And that on average, if they were using it for more than 400 cases per year, they were making money. They were saving money over doing open surgeries. And this was even before a lot of the later data had come out. And so to date, there's over 7,000 peer-reviewed journal articles looking at outcomes associated with use of this technology, and the more recent ones have been on these sort of large population-based studies. Go over to a country like Sweden, and they're making very different sorts of decisions. In Sweden, the healthcare system covers not just the acute hospitalization, but also the long-term healthcare before someone returns to work. And so they were very interested in what does an investment in a healthcare technology that does minimally invasive surgery do in terms of the overall economics associated with a return to work. And people returned to work after 49 days with open surgery and within 11 days after they've had the minimally invasive surgery, the Da Vinci surgery. And so for them, the healthcare economics were dwarfed by the time off work. And in the Northern European countries, we see some of the highest levels of robots per capita of anywhere in the world because of this kind of calculus. And so when you're looking at the price tag of an expensive piece of capital equipment and the effect that it has on payers and patients and providers and society as a whole, there are different levels of calculus. Each group is deciding on this in a different way. And so the patients, it was obvious, you want to go from a large scar to a small one. The payers were seeing a lot of benefit in terms of complications and readmission rates that they were not having to pay for. The providers were seeing also similar benefits in terms of not having to readmit and dealing with lower complication rates. And society as a whole, especially when it's a single payer system, was seeing these benefits as well. And so this is what the ORs are starting to look like. And the Da Vinci is not the only robot that's out there that these kinds of decisions are going to have to be made about. In fact, it wasn't the first surgical robot either. There were several different kinds of robots, from a transurethral prostatectomy robot to the Minerva surgical brain surgery robot, to RoboDoc in the corner, which is improving the outcomes associated with hip replacement. We also see several more robots in the area of orthopedics that are coming down the pipe, from the Rio, the Mako Rio, which is to improve the placement of knee implants and hip implants so that you get better long-term outcomes and the replacements are more durable, to the Mazor, which is a spinal robot for improving the way fusions are being done. So more and more people are bringing these kinds of high technology systems to play in delivering more precise outcomes. There's even a large area in which flexible robots are starting to come in, from catheter-based robots where you can steer the catheter up into the heart to do ablation, to robots that will make colonoscopies more comfortable, to robots for doing surgery inside the GI. So I've woven a good story about how good this technology is and how much money it's saving and how all of these different robots are going to be improving clinical outcomes. And the data are true that it is improving outcomes, but pretty much all of the improvement is coming from this transition, taking an open incision and making it smaller. When we look at the benefits, everything is coming from this aspect of it. And we're still doing the same surgery inside. So although we're doing it with these very, very high-tech instruments, I'm going to argue that this is not enough. This is not really that much better than this. So these are surgical instruments that were unearthed in Pompeii. And if you look all over the Middle East and North Africa, you see evidence of surgery going back thousands of years. And the surgeries that we're doing inside the body right now through these high-tech, very small incisions really aren't any different from the surgeries that we could be doing like this. The better outcomes are coming from the access method, but we're not fundamentally changing surgery. And to give you an example of why this is important, I'm going to talk a little bit about lung cancer. So if you are diagnosed with lung cancer today, and you have a stage 1 cancer, so it's very small, it's confined in a certain area, you have a 77% chance of surviving 5 years. If the tumor is a little bit larger, but still confined to the area, it's about 58%. We start to get lymph nodes involved, you have a 50-50 chance of surviving to 5 years. 35, once we start to get more regionally located. 31% when we start to involve the local lymph nodes, and 11% if you've got distant metastases. the worldwide average life expectancy after diagnosis with lung cancer is 15% survival at 5 years. And so what that says is that we are not finding it at stage 1 or stage 2. We are finding it somewhere between stage 3 and 4. We're finding it when it presents clinically. I can take it out with my robot. I can give you small incisions. You can go home soon, and you will still die within 5 years because I haven't fundamentally altered surgery. I have just done it in a less invasive way. And so when we're talking, so this is what I'm passionate about. This is the kind of research that I'm looking at. How do I fundamentally change that disease state so that when I do surgery on you, it is curative and you do last 5 years? And so some of these technologies are going to be kind of strange. This is a dog's nose. Dogs have been trained to smell lung cancer. In fact, they're better at detecting some forms of lung cancer than any of the imaging studies that we can do. And so we know that the chemical composition on our breath is somehow indicative of the lung cancer in our lungs. And if dogs can detect it, we must be able to develop devices that will allow us to screen and find this earlier. And then what we can do is we can push down the diagnosis level. We can start to find it at stage 1, and we can start to do surgery when it's curative. Or maybe a revolutionary technology is going to look like this, where we figure out how to make your immune system take care of the cancer. So instead of doing a big salvage surgery, I go in and I biopsy. I get a sample of that tissue, which we can then present to your body's immune system outside. We can potentiate your immune system, and we can put it back in, and you can attack the cancer. And so we're not doing big salvage surgeries. We're harnessing the body's ability to get rid of this. Or maybe some of these revolutionary technologies are going to look like this. These are viruses, adenoviruses, that affect and kill breast cancer. And so instead of going to your GP when you have a cold and saying, can you give me something for this cold, you would go to your GP to get a cold. They would give you the adenovirus, and it would go and mop up some of the cancers in your body. It's these kind of far-out technologies that we have to start thinking about as we want to take it away from just doing the big salvage surgeries that we're doing and be able to really fundamentally move the needle on how we're doing therapies. And so what gets me excited is robotics allows us to change the scale of therapies. I can work on an individual cellular level. I can drill a hole in an individual cell if I can detect that that cell is the cell that I need to be able to kill. I can unwind cancer from around a neurovascular bundle and leave everything in place, leave the person whole and intact. So these are the kinds of things that we really want to be able to do. I can also, onto these robotic platforms, bring new forms of vision, where with fluorescence vision, I can tell the difference between cancer and not cancer. I can make a much better intraoperative clinical decision-making that allows these cancer operations to be curative. And the key to all of this is the research that's unlocking a lot of this knowledge. And so when I'm going out and I am looking for things, this is the way I look at the world. I am constantly looking in multiple different directions for many different technologies that are outside of my area of surgery and saying, how can I bring them in? How can I use them to disrupt the way we're doing these kinds of therapies? Because continuing to just do the same therapies over and over again that we've been, quite frankly, doing for 1,000 years isn't going to fundamentally change what we're doing. And so just to give you a little taste of some of the technologies I'm looking for, they tend to look like this. Early, ugly stage, and we don't yet know what they're good for. So this is the first transistor out of Bell Labs in 1947. And the people that were making this had no idea what it was going to do and how it was going to transform. And if we go back and we look at the technologies from this time, 1947 is about when my parents were about 10 years old. And this is what a radio looked like, vacuum tube. This was the fanciest code cracking computer available that had just come online. And this is what a mobile phone looked like. They were actually radio-based, and they were in Southern California. Oh, and incidentally, 1947 is about the time when the Americas and Europe started to have long life expectancies. 1979, that's about when I'm about 10 years old. And this is what a portable music player looks like. These are the Cray and the Apple. This was changes in computing. And I'm kind of cheating on the cell phone. It wasn't quite available yet. But that's what the prototypes looked like in 1979. I have a 10-year-old daughter. This is what a computer, a music player, and a phone looks like to her. It's come a very long way from that ugly bit of technology that we saw. And it is indicative of the way in which these technologies change and transform. And so as we continue to go out, and this is something that I'm always doing, I am looking for ways in which we can really improve patient outcomes and how we can fundamentally change it, because I believe that these kinds of technologies are going to give us medical superpowers. They're going to let us see beyond what people can see. They're going to let us reach beyond what humans can reach, and they're going to let us really affect these kinds of therapies and change, fundamentally change the way we are approaching many of these disease states. So with that, thank you.
Thank you, Dr. Catherine. I think this was inspiring. And I'm still stuck in the dog nose and my brain cells. Yeah. Anyway, so for the next speaker, I'm honored to introduce Dr. Alan Cheung. Dr. Alan is currently director of the Hospital Authority in Hong Kong. His main work portfolio includes overseeing services operation and transformation. In addition, Dr. Cheung oversees the medical, nursing, and allied health grades management and development. On the clinical side, Dr. Cheung is an expert in emergency medicine. One of his special interests is disaster medicine. He is fellow of the Royal Australian College of Medical Administrators, the Hong Kong College of Community Medicine, the Hong Kong College of Emergency Medicine, and the Hong Kong College of Surgery. Welcome, Dr. Allen, and this is your time for your presentation, please.
Good morning, everybody. So thanks a lot for inviting me to this very beautiful country. This is the second time I was here. Last time is 2 years ago, and there's a lot of new development already coming up when I arrived this time. This is where I come from, Hong Kong, a very beautiful city. It's situated in the southeast side of China. It's a very tiny spot. You have difficulties in identifying this tiny spot in the world map. Today is still the Chinese New Year, back to Hong Kong and China, so I would like to take this opportunity to wish you all good health and have prosperous years on the Year of the Horse. Hong Kong is very famous for its night scenery. According to some tourist guide book, it's already ranked at the top among the all over the world. But Hong Kong is going to be a little bit more famous because of its healthcare system. Because last year, 2013, the Bloomberg ranked Hong Kong as the most efficient healthcare systems among the developed countries. So what's fascinating for Hong Kong healthcare system? Hong Kong has a population of 7.1 million, and the GDP per capita is around $31,000 per annum. The life expectancy at birth now, 2013, is on average 83. It's now the top amongst the well-developed countries. And infant mortality rate and maternity mortality rate is also leading. In terms of GDP spending, we are relatively low as compared with other developed countries. The spending is only around 5.4% of the GDP on healthcare. In our system, we have a dual-track system. The public system, which is funded by the government mainly, highly subsidized, and the GDP consumption is only 2.4%. And among this 2.4%, 10% is on public health, and 90% is on medical care. This public system shouldered around 1/3 of the outpatient primary care services, mainly targeted to the lower social class, professional clinical teams. We are the people service. So quality people will produce quality care. I will only elaborate on 2 areas, which is the first one and the third one. Effective healthcare systems suiting local environment. No matter where you are, no matter which country you are, there must be a historical development. There must be a cultural component, and always healthcare is under evolvement. And there's 2 parts. One is the health systems to promote and ensure health, and the second is a sustainable medical system to provide universal coverage and accessible and of standard care. Here, there are 4 aspects in terms of the health system to promote and ensure health. I will share with you some of the figures in the past years in the Hong Kong health sector, and we'll give you some insight of what's happening in the past 30 years. So here's the analysis in terms of the major mortality rates, date back 1981 and 2012. So it's more or less around 30 years apart. So I would like to draw a little bit attention to some of the findings there. In terms of injury, I think it's a concern here. Previously, date back 30 years ago, that's around 10%. And now has been reduced to less than 4%, and it's a basket embraced in a basket of other things. So the Hong Kong city now is much more safer, and the incidence for injury causing death is very minimal. The second part is on the diagram on the right side, okay, the cancer. So cancer is a theme, it's a major issue, but in terms of mortality as a cause of death, as compared with 30 years ago, there's only growth in 2% in absolute magnitude. I will tell you why later. And on the lower side, so there's the cardiovascular and also the cerebrovascular situations. There's a major reduction as a cause of death. If you add them together, there's major reduction in terms of more than 10% in absolute terms. On the left-hand side, the growing sector, which is pneumonia, it's maybe a little bit surprise to you. We are not talking about treatable chest infections. We are talking about end-of-life events, which ultimately people die, and the precipitating event is usually chest infection. That's why pneumonia nowadays is an event of the end of life. It's nothing related to technology, treatment, or use of antibiotics, because people eventually die. Let's see the prevalence of these chronic situations. Just the top 4, hypertension, diabetes, heart disease, and high cholesterol, there's multiple fold in terms of their prevalence, ranging from 2 times increase to 3 times increase. This is mainly due to the increase in average lifespan. When we date back to 1981, the average lifespan in Hong Kong is 75 years. Now it's 83. When people get older, they will have more chronic diseases because the machinery within the body will degenerate, and chronic diseases will be the major health spender in the future. Cancer, let's go back to cancer. The prevalence is 3 times as compared with 30 years ago. But in terms of mortality, it's only 2% increase in absolute terms. Even if you talk about relative terms, it's only talking about 8% increase. Why? It's because nowadays we got early detection of cancer. We have better treatment for cancer, and seldom, much less situation, the death is due to cancer care. And death due to other reasons may also happen for a cancer patient. One thing I would like to point out is the mental and behavioral disorder. Now it's getting more and more attention, not because that there are more incidents, because of more awareness of mental health. So awareness and lifestyle, healthy lifestyle, actually goes hand in hand. And there are good progress in Hong Kong. Next week, we will have a marathon competition, and probably it will be difficult for you to guess how many participants is going to join the campaign. So 70,000 residents of Hong Kong will join the marathon run. It represents how health conscious are people. But it takes a lot of years for this to build up. Smoking is more, again, you can deliver results with better tobacco control. And over 30 years, we are able to reduce the smoking from previously 23% to now 10%. So we are going to have further control to bring this down into a single digit. And we all know smoking is highly related to it's definitely a health hazard and highly related to respiratory disease, even cancer. The disease prevention programs and chronic disease management is very important because in the future, our health expenditure will be mostly on chronic diseases. I will only highlight two aspects. One is vaccination and cancer surveillance. Vaccination, we are talking about not just preventing or minimizing infection. We are talking reduction of cancer incidence. For example, in the Southeast Asia, hepatitis B infection as a carrier state is a major problem. And then that's why the liver cancer subsequently is high. When we have introduced the vaccination of hepatitis B virus, day back 30 years ago, we are expecting a very major reduction in liver cancer incidence maybe 20 years later because people need to grow older in order to have the cancer. Cancer surveillance is also important in the sense that you can early detect them, you can treat them, and probably there could be a cure, but has to be considered with the evidence-based approach. In Hong Kong, we have this cervical cancer screening, and we are going to launch the colorectal cancer screening because the incidence of colorectal cancer is increasing in Hong Kong, and it's going to be the most leading cause of cancer in Hong Kong. That's why when we talk about cancer surveillance, it has to be evidence-based approach and has to be related to the epidemiology of the local situation. For other chronic diseases, I think on the right side, so it's the major issues, the risk factors, which we need to control. And we will reduce stroke, it will reduce a lot of other disease complications. On the medical side, medical system side, the Hong Kong government actually provide a universal public health care services coverage to the population through the hospital authority because we provide a very inexpensive services to all the people of Hong Kong. And it's like an insurance system, but we do not have a national insurance scheme. This is the charges we are charging. Just take an example of an acute general bed. For any one day, which is all inclusive, surgery, CT, MRI, ICU, whatever, the cost to a citizen in Hong Kong is only $13 US, so more or less free of charge. And that includes free meals provided. And under that situation, you can consider actually that hospitalization is actually free of charge. So our key features here is universal coverage with system of choice. Everybody can go to the public sector. If they choose to go to the private sector, they are welcome as well. It's a very high professional standard of care. The government is only responsible for 44% of the healthcare expenditure because of the coexistence of the private sector. And we have a very highly efficient public system serving 42% of the population because not every citizen actually will come to the hospital authority. They may, for minor illnesses, they will prefer to go to the private sector. And it's a sustainable system with leading health outcome supported by low percentage of GDP. So I'll also talk on about anticipative demand and service planning. We adopt this framework. The middle and longer term is strategic planning. It's where we want to be. And then we have a middle range service planning in terms of geographic facilities planning and also specialized services planning. For example, stroke service, cardiovascular services, psychiatric services planning. And every year, depends on how much money we have, how many manpower we have, then we materialize this services enhancement through the annual planning. And that will take care of both the hardware side and also the software side. We use 2010 as a baseline and use the past figures for analysis, and we project 20 years to 30 years later. I think the top three is the most important. First is demographic changes, the population increase, the aging. Second is the demand per capita by age group, by sex, and then the technology advancement. And for the others, it's also a basket of consideration. I will only concentrate on the first three. Here give you some figures about the aging population. In the years to go, by around 20 years later, the percentage of residents in Hong Kong above 65 years of age will increase disproportionately to the increase in population in Hong Kong. So we are talking about a major increase in the elderly group. And we all know people grow older, they need more health care. Just to focus on a few figures, the hospitalization rate of elderly people is 4 times that of the non-elderly. And this is the hospitalization rate by different age band. You will appreciate how fast it actually goes up when people get older. Elderly people's requirement for hospital bed is 9 times that of the non-elderly because they, including acute, convalescent care, rehabilitation care. This is how actually you need to plan your facilities. And if we know the workload going ahead in the future, and we can establish the manpower time per workload unit, then we can know how many different kinds of manpower actually we need, including doctors, nurses, allied health in the future. Technology planning is also a main theme here today. There's 5 important aspects: the strategic objective of where you want to be, and then the technology scanning of what's happening in the world, a benchmarking across different countries and regions, and then have a system to do the technology assessment, and then to prioritize your investment. Here's something we have done back to 2008. We try to benchmark ourselves in terms of technology level. We find ourselves under the group of the consensus adopter. That means that we are not go too far, okay? For well evidence-based technology that has been proven to be effective, we want to introduce to Hong Kong. When we compare with other countries, we are a little bit behind in terms of this consensus adopter group. We also done the benchmark across different services as well, and we can see our position. We are under some area, for example, under information technology, we are quite leading. And in terms of radiology, cardiovascular, we are a little bit behind. So once we know where we are, where we want to be, then we can prioritize our investment. Financial planning, again, very important, because if we don't have the money, then it's very difficult to sustain the healthcare services. The main drivers are 2. One is demographic changes, which with the background information you know. The second part is medical advancement. I just want to elaborate that there's 2 important components. With medical advancement, it will generate activities because with better technology, you can treat more, you can treat better. The second is the cost of service. Technology comes with a price, and we can see that the future technology, the price is even higher. So with this, we have done a proxy on how to look into the future. We use the acute inpatient bed days as a proxy, and once it's adjusted to the price level, and we find that it actually represents the total healthcare expenditure on the public sector side. And having this proxy, then we will do an analysis in terms of different age banding. On the left side, the very steep slope, it represents the increase in medical provision. And the drop represents the introductory of ambulatory care. And afterwards, it's quite stable, with the elder age group slightly increased and the young age group slightly decreased in terms of hospitalization rate. With this, then we can look into the future in terms of the acute inpatient bed days 20 years, 30 years down the road by get into consideration of the population structure. And then we'll build in a component of activities increased by technology, introduction of technology. It's based on past figures. And then a cost component, which is quite alarming. And we have done some results. I just want to show you just this one. This is I would call a fair representation of the Hong Kong situation. The increase in activities is around 2.something% based on population. And then for technology-wise, in terms of activities, it's 0.67%. And in terms of cost, it's around 2%. But we are not confident that this is the picture. So we do another scenario, which if we are talking about an escalating cost of technology in the future, the projection can be purely for technology-wise can be 5%. It's compounding every year. So 20 years, 30 years later, it will be double, triple, or even 4 times the current expenditure. So it's very important that the government need to plan for the financial situations to sustain the healthcare development. So with that, I end my presentation. Thank you.
Thank you, Dr. Ahmed. This is really interesting. As we see here on the floor, we have a technology and a regulator being aligned with each other. So I will ask Dr. Catherine, from your journey with the Da Vinci, how did you come over the challenges with the regulators on implementing such technology in different countries?
Well, there's different types of regulation. There's initially, in the United States, the Food and Drug Administration that just says, can you even use this? And in Europe and other parts of the world, there's the CE mark and local regulation on whether you can use it. That's only the first regulatory barrier. The second one is on reimbursement and a decision to adopt and a program to adopt. And with each one of those comes an issue of how, with the adoption of a new technology, are you going to train your existing medical force to be able to use this new technology effectively? And so there's multiple levels of these kinds of barriers. And we've seen the adoption be different. I tried to touch on that a little bit in my presentation. We've seen that there are different drivers for adoption and different barriers for adoption worldwide, and you just take it on a country-by-country basis.
What about the surgeon themselves? Usually we based our decision on evidence-based medicine. I think from the beginning, from day one for the Da Vinci, was not proven effective. You took time to prove it, and then to be published all the results in the journals.
Well, and that will face every single technology coming out, because as soon as a new technology is introduced, it will not have evidence, because especially for cancer, it's generally 5-year survival rates, which are considered the metric by which you judge a new technology, and you wait 5 years plus for those sorts of results. And so we see great variation in individual physicians and individual hospital systems in terms of, I thought you put it very well, in terms of where on that adoption curve either the physicians or the hospital systems are philosophically. Do they see themselves as, we're going to bring out the newest?
Yeah. Yes, continue.
Yeah. Or do they see themselves as waiting until there's a preponderance of evidence before they adopt?
And Dr. Allen, from your perspective as a regulator, are you afraid from the technology being introduced to your system, or what are the challenges you are facing in this regard?
I think technology is the future. We have to introduce technology to our health system, otherwise we'll be lagging behind and people will be suffering from their diseases. We have also 5 Da Vinci machines in Hong Kong. Okay? It will be a surprise to you why we got 5, because it's more than what we want. Actually, we are not buying, it's through donation. A lot of rich people are very fond of high technology. They donate this very expensive machine to the Hong Kong system. We are lucky to have this system, but we have several issues. One is because even for government, spending a capital expenditure may not be a major issue because it's one-off expenditure, but the recurrent becomes a problem. So in terms of consumable-wise, though, it's quite expensive. The second is training. It requires a training of the personnel, especially surgeons, and there's a learning curve. So it requires some time to learn. But it also creates some sparkling among the healthcare professionals, because once we introduce first one, the young doctors always want to have the opportunity to run the machine because it's so wonderful, and we will improve their prestige in terms of handling new technology. And we need to really coordinate our training. And the third one is the operation time, because as you know, an open surgery probably 1.5 hours. Da Vinci machine or other laparoscopic surgery require longer time of operation. So the theater operation time become an issue. But definitely we welcome technology assessment.
Now, Dr. Catherine, from your experience with Da Vinci, where do you think we are going in the technology part? What does the future look like for us?
Well, I think what we have seen is the real strength upon which the adoption of the Da Vinci has been was moving it from open surgery to minimally invasive surgery. Where the focus of my research is now is helping improve clinical decision making. Can we bring fluorescence technology in so that you can better differentiate between cancer and not cancer? Can we bring the ability to navigate so that you can unerringly find where the tumor is and you can work more rapidly? And so I see it more as a platform technology onto which we can bring other synergistic technologies that improve our ability to improve patient outcomes.
And you mentioned in your presentation regarding the most effective treatment for cancer is prevention. Do you think technology can help us in the prevention side?
I think we know a lot of the things that we need to do on prevention. They're just hard to do. It's from cessation of smoking and avoiding obesity and not having terribly many chemicals in our environment. Cancer, however, is not entirely preventable because it's a function of our repair systems within our body. And so to live and to live for a long time means to live with the specter of cancer. How I really see us engaging this more effectively is driving that diagnosis earlier and earlier so that we can do a small procedure, a maintenance, like, for example, taking a mole off of sun-exposed skin. We don't think of that as a very traumatic thing. If we can reduce finding your lung cancer to the point when it's that small and we can get rid of it at that point, we look upon cancer therapy as maintenance and not as salvage.
I would like to maybe share that. What's the actually impact of technology introduction to the whole population? In general, technology can treat better, produce better outcome, and people live longer. That's the result. And there could be healthy aging so that people can work, go back to productivity. But in terms of healthcare-wise, you need to put in more maintenance every year for everybody. So it's a balance that you will eventually win out by having increased the productivity of your community. But the more you invest, the healthcare cost will go up, but it's worthwhile to do so.
Yeah. And Dr. Allen, yeah. Yes, Dr. Amma. Mic. Just the mic, please.
Thank you. Dr. Allen, you clearly have a very impressive healthcare system in Hong Kong, and you know it's clearly not for nothing that you are top of the 58 countries that have been assessed for healthcare. What are the most important initiatives you do that have been important in containing cost? Because I think cost is an issue around the world. We hear it almost on a daily basis in other countries. So perhaps you can share with us some of the initiatives Hong Kong has been successful in for containing cost.
First, I would like to share about the cost structure in Hong Kong. Cost structure, our spending in terms of the human resources, salary payment, is around 75% of our recurrent. So Hong Kong people, professionals, are receiving quite a good salary in terms of that. So our expenditure for the non-PE is around 25% only. So in general, our cost structure is not inexpensive, it's quite expensive. But how can we be so cost efficient in terms of delivering that? I think can be summarized into a few things. One is a good assessment of what you want to introduce to the community through an evidence-based approach. Make sure that there are evidence, there are good outcomes before you introduce a technology. That's the first one, evidence-based approach. The second, you define your standard of care to the people that you want to provide. Because people always want the best care, and best care usually come up with high cost, but can be marginal marginal outcome. So where to draw the line becomes very important. And you need to manage expectation of the community. I think that two key things represent how we can be cost effective. Of course, we need to have an efficient system. I don't have time to go through the other aspects, but our system is quite efficient in terms of we call it a cluster management. That means we try to regionalize, and then hospitals will collaborate with each other.
Great. Dr. Catherine, do you think technology reduced the cost?
Well, to Dr. Allen's point, when we're extending the life of people, that does come at a cost. I mean, as we bring people and enable them to live longer, we will be dealing with chronic management of older people. Now, that said, I do believe that there are technologies that can drive cost in the correct direction. I mean, we've seen with the adoption of our technology that there are hospitals that are managing to save money with it, just because of the efficiencies associated with the care and the reduction of complications. I think with every new technology that you're bringing in, you really have to be assessing the effectiveness of the care versus the cost, and how is that affecting that balance. And many technologies that we see, from vaccinations to screening technologies to even some of the higher tech surgical technologies, are reducing.
Some technology can reduce healthcare costs.
Yeah.
For example, those reduce length of stay, reduce admission. For example, an intravenous drug which require daily infusion now have an oral form that you can go home and then take yourself. So that will reduce healthcare costs. But the others, it will bring you good healthcare outcomes.
And just going back, and I'm thankful that you mentioned the community expectation in your presentation and your answer to Dr. Amaha. But now Hong Kong, they have low infant mortality rate, high life expectancy. But I will feel there are challenges facing the healthcare model in Hong Kong. I don't know what are the examples of challenges.
We have multiple challenges, similar to every region and country. At this moment, we have major two challenges. One is we are suffering from a very severe professional manpower shortages. And that's a very painful experience because day back 10 years ago, Hong Kong's economy have this financial tsunami. It's a very dramatic economic downturn. And the government reduced the healthcare funding. And it closed down the annual medical student intake and nursing intake as well. Reduced. And that's why after 8 years, 7 years down the road, we have having this very severe manpower shortage. So very important is the government need to have a system to sustain the health expenditure. The second is we do have a waiting time issue. People need to wait if they are not having an emergency situation, and it's deteriorating. Not because of money, it's because of the manpower shortage. We don't have enough doctors and nurses, and that's why we cannot keep up with our supply, of services to the demand of the public. So careful planning is so important.
If anyone has a question, let's have the mic, please. Here.
Dr. Catherine, I was wondering how risky is it to give to share the operation, that the doctor shares an operation with a robot? And does this mean you require less talent? I remember in the 90s when my father, who is a neurosurgeon, started to use the microscope to operate the spine, human spine. This was the non plus ultra. Now robots move into the operation rooms. And question to Dr. Chang, traditional Chinese medicine exactly does not require a lot of technology. Now you say in your presentation, culture is very important in the future healthcare system. How do you solve this obvious apparent contradiction for the future healthcare in Hong Kong? Thank you.
Okay, shall I take mine first?
Yes, please.
So the robot is not an independent device. It's a telemanipulator. So the surgeon is still doing the surgery, but they are telepresent within the body. And what that means is they can see everything that's going on, and the motion of their hands is being reproduced exactly by the motion of the instruments inside the body. So the surgeon's clinical judgment is still very much in play. placing a technological step between the surgeon's hands and the patient's tissue, and the surgeon's eye and the patient's tissue, has a risk if that link goes down, but it has a great potential for benefit in that we can introduce additional information into that loop, we can reduce tremor on the part of the surgeon, and we can improve the scale of the motions that they're making. And so all of these things tend to make the surgery easier to perform rather than more difficult. I don't think the availability of this type of technology is necessarily going to drive the quality of our training down. We will still expect high quality out of our medical and surgical professionals. So I don't think we're going to adversely affect training by making surgeries more effective.
Traditional medicine in Hong Kong's perspective is Chinese medicine. And definitely Chinese medicine is effective. There's no question on that because it's been proven over 3,000 years. The mainstay of care is still Western medicine in Hong Kong, and Chinese medicine play a complementary role. The key link of integrating Chinese and Western medicine is the evidence. How can we establish an evidence-based approach in drawing the benefit of the two systems together? So that's why we are at this moment leading a program which try to integrate Chinese and Western medicine on very specific targets and try to define the protocol clearly, what's the treatment target for different streams of medicine, and try to monitor the effectiveness and side effect as well. But probably it takes some more time for us to materialize that.
Does this fall under your authority or the Department of Health?
Or is under my profile within the hospital authority. The Department of Health do the regulatory, okay? They ensure the safety of everything, control of licenses in that aspect. But in terms of provision of services, the hospital authority is doing.
Well, and we're seeing the adoption even come Western. As a medical student, we had a patient that had terrible gastroparesis, paralyzed stomach as a result of diabetes. And acupuncture was the thing that we actually used to treat this. So when there's evidence, there should be adoption.
Yep.
Yeah, I am a United Nations senior researcher and advisor on mobile services and smart cities. My question to you, Dr. Catherine, is, and of course to the gentleman, if the governance. I'm not talking about the drug and food administration thing, like who can use what drug, but there are so many smart sensors and technologies are coming around. Young people can easily program mobiles in order to send such health data, etc. Is there in the United States or elsewhere in the world an e-governance or e-health governance? Who does what, who authorizes what regarding ICT technology, not drug and chemical technology? Thank you.
Well, in terms of the data that's available on the robot, it's generally confined. The robot itself has no way of knowing the name or the medical record number or the identity of the patient that is being operated on. That is still entirely within the purview of the medical system and the surgeon. What data can be gleaned from these is what kinds of motions are being made and what sorts of instruments are being used and things like that.
I'm not talking about the robots, I'm sorry, madam. I'm talking about the smart sensors or applications. If a company, like a technology company, comes up with a new invention that can touch health, which is available to the common citizen, to the common patient. Yeah, thank you.
So what we have seen in many cases with these kinds of innovations coming out of Silicon Valley is they get ignored by the regulatory agencies until they start to have a significant usage. And as we saw with something like 23andMe and also some mobile health applications, there were, until they were in large enough use, they were largely ignored. And then at that point, the regulatory agencies were trying to play catch up and trying to figure out how to regulate these things. And the pace of technological change is straining regulatory agencies to their limit. They don't really know how to assess these. They don't know whether to deal with them as a drug or a device or some combination thereof. These mobile data applications are really quite challenging from a regulatory point of view. I see them getting sorted out the same way I see many of the like genomic and proteomic based assessments being finally figured out. But it's going to take a while. As these new technologies come up, these systems are going to have to adapt and figure out how to address them.
And mobile technology definitely will play a very important role in terms of making correct information available to individual patients or healthcare providers. And the mobile application can do so. But the key challenge is not the technical side, it's whether you have a good database available for you to send out this information. For example, if we can have an infrastructure where all the medical records or medical data of individual patients are shared across different sectors, and some of this information or data can be organized in terms of useful information and go back to the patients. It will help the patient to understand his health or her health and then modify the behavior as well.
Dr. Allen, how you control the quality of healthcare in Hong Kong?
By running these public healthcare services, apart from being efficient, okay, we need to be really effective. And that's why we have system in place to ensure that the clinical care we deliver to the patient is of standard. And one advantage we have is that we are a single system, the hospital authority, and all the public hospitals are under the same IT system. So all the clinical information, okay, we will be made available to us in terms of performance, clinical effectiveness, utilization of resources, et cetera, And we use this database to build management information in terms of quality control, in terms of performance management, in terms of key performance indicators, financial performance, et cetera. It helps us to do a lot of this checking in terms of whether we are doing good, we are on the right track or not. And of course, on the clinical side, most important is clinical governance. Clinical governance goes back to the professionals. They need to have a culture of constant audit and self-improvement.
And what is your advice for the coming 5 years, for example? What do you think the right healthcare service delivery model that it needs to be adopted, or you can see it's coming to be part of the different countries of the world?
It would be difficult to say so because different regions, different countries will have different challenges. So depends on the priority of what they want to do. Okay, so they need to do some healthcare reform or change in development. But I would like to share some of the so-called future technology that will be coming in. The genome analysis is most important because I know that the technology is coming up that you can really draw a sample of your blood and then do an analysis there, and then you will find out what's happening wrong within your body. For example, what sort of cancer you are having. It's not too remote, it's coming. The next one is the nanotechnology, okay? And the third one is robotic, which we have talked about, robotic applications in terms of treatment. So all these three things are the major development in the coming 20 years: genome, robotic, and nanotechnology.
Any more question from the floor? Yes, please.
Thanks a lot for this impressive really presentation. It's a concern now in the healthcare system all over the world, either it's in states or in the Gulf countries or in the developing countries. And I tried to get it up from your speech, but still maybe your experience might help us. Now we have always, whenever there is an initiative in the healthcare system, always we look into the three domains. We look into the capacity, we look on the demand, and then we look into the patients. Now, with this technology revolutions coming, either in the surgery or in any healthcare system, now how we can map it, considering the time factor, the demographic changes around the world is growing fast, and we are the public and the community are in the expectation that the healthcare system meets their demands. One of the aspects now came up is the technology revolution in the healthcare, and the time factor, it doesn't help us especially when we have to consider the cost, we have to consider all the other resources. So how we can overcome this challenge, considering the three aspects, the capacity and the demand and the patient.
Can you repeat the last bit of your question? How can we?
How we can map the three, the capacity, demand, and the patient with the technology revolution, considering the time factor, because we have to grow fast, we have to, meet their expectation at the same time. So
maybe I share my idea first.
Yeah.
I think the key is anticipative planning. You anticipate what's happening, will happen in the future, and you try to plan for what you want to do. Because most of the situation is reactive planning. Most of the government do reactive planning. They see what their major challenge now, and then they try to improve their systems to solve the present challenge, which is lagging behind. So we are also having very painful experience in our system that we are too reactive. That's why in my presentation, we encourage people to go looking forward. You anticipate the problem, you plan for the problem, and the problem should not arise. So that's the vision. But of course, all projections will go wrong.
Mm-hmm.
So don't be superstitious in terms of projection.
Yep.
Dr. Catherine, final
Well,
statement?
and I was going to say, just in terms of technology development, we sit in a similar world. We're looking at these large demographic changes. We're looking at healthcare cost constraints. We're looking at outcomes from a patient-centered point of view. The development cycles on technology are also very long, and it can take 5 to 7 years to get a new product out and into the market. And you have to be anticipating, where will healthcare be when you bring this new product out, and will it be relevant to the problems that are facing healthcare at that time? So we're all trying to figure out what's going to happen in the future. We're all trying to plan where it's going to be and be responding appropriately. And all we can do is just keep adding new data into our models and plan, be willing to be wrong, replan.
Thank you, Dr. Catherine. I think this was an inspiring and enlightening session. Thank you, Dr. Catherine Moore, for joining us today, and Dr. Alan Chong, thank you very much. I hope this was beneficial for all of you, and I wish you to enjoy the rest of the government summit. Thank you very much.
Thank you.